Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. In July 2026, the FDA approved a new drug for a disease that quietly destroys kidneys: IgA nephropathy. The drug is Atacicept, and it works nothing like the treatments before it. In this video, we'll break down exactly how it does that, the receptors, the pathway involved, and what the trial data actually shows. First, quick refresher. IgA nephropathy, also called Buerger's disease, is the most common primary glomerulonephritis in the world. It hits young adults hardest, typically in their 20s and 30s. The classic explanation is the four-hit hypothesis. The body produces IgA1 antibody missing a sugar cap it's supposed to have. Undergalactosylated IgA1, in medical terms. That cap normally hides the antibody from the immune system. Without it, the antibody looks foreign instead of familiar. The immune system spots these antibodies as foreign and makes autoantibodies against them. Those two antibodies bind together into immune complexes, clumps that circulate in the blood. Those clumps get trapped in the glomerulus, the kidney's filtering unit, and trigger inflammation, scarring, and progressive loss of kidney function. Left untreated, roughly half of patients end up in kidney failure. Until recently, nothing stopped this at the source. We could only manage the fallout, treating blood pressure and protein loss downstream. So, if the disease starts with faulty antibody production, the obvious drug target is the cell making that antibody: the B cells. Two signaling proteins control whether those cells thrive. BAFF, B-cell activating factor, and APRIL, a proliferation-inducing ligand. Other immune cells release them, and they dock onto receptors on the surface of B cells: BAFF-R, TAC, and BCMA. As a B cell matures, it displays different receptors. BAFF-R is there from the very start, keeping the B cell alive day to day. As the cell responds to signals pushing it toward a particular antibody, often IgA, TAC ramps up and helps drive that switch through. BCMA shows up last, once the cell has fully matured into a plasma cell, a long-term antibody factory that settles into the bone marrow. Every time BAFF or APRIL dock onto any of these, the message is the same: stay alive, keep maturing, keep making antibodies. But these three receptors aren't identical. BAFF-R only answers to BAFF. BCMA mostly answers to APRIL. TAC is the one receptor that answers to both. And it shows up right at the stage where a B cell is committing to produce IgA. That's the exact stage this disease runs through. In IgA nephropathy, APRIL does most of the direct damage. It drives B cells toward producing that broken undergalactosylated IgA1. But BAFF still matters. It keeps the upstream pool of B cells alive, before they've even committed to making IgA. So the strategy is simple. Block BAFF and APRIL before they reach any of these receptors, and you starve the cells producing the problem. This is where Atacicept comes in. And the design is clever. It is a fusion protein. The extracellular, ligand-binding arm of the TAC receptor is stitched onto the tail end of a human antibody. That design does two jobs. First, because it uses the TAC receptor's binding arm, Atacicept grabs both BAFF and APRIL. TAC is also the receptor that shows up as a B cell commits to making IgA. So, atacicept catches them at the exact stage this disease depends on. Second, the antibody Fc tail keeps it circulating in the blood for a long time. So, it acts like a decoy receptor floating around the bloodstream. Mechanistically, atacicept enters circulation and soaks up free BAFF and APRIL like a sponge, mopping them up before they ever reach the real TC, BAFF-R, or BCMA receptors on B cells. No ligand reaching the receptor means no survival signal. Without that signal, B cells, including the ones producing defective IgA1, die off and antibody production drops. Downstream, that means less broken IgA1, fewer immune complexes, less buildup in the glomerulus, less inflammation and scarring over time. Atacicept is a once-weekly subcutaneous injection, delivered through an auto-injector patients can use at home. A real upgrade over infusion-based treatments. Now, the evidence. Atacicept was studied in Origin 3, a phase 3 trial of 431 adults with IgA nephropathy. All on standard supportive care. Randomized to weekly atacicept 150 mg, or placebo. At the planned interim look, patients on atacicept showed a 46% drop in proteinuria from baseline. A 42% reduction compared with placebo at 36 weeks. Proteinuria is a marker of kidney damage. Here's the catch. This was an accelerated approval, granted on proteinuria alone. Whether atacicept actually slows the long-term loss of kidney function is still unproven. Continued approval and staying on the market depends on confirmatory result. On safety, the two standout side effects were infections and injection site reactions. That tracks with the mechanism. You're dialing down part of the humoral immune system, so infection risk needs watching. And live vaccines are generally avoided. So where does atacicept sit in the treatment landscape? Until a few years ago, there was just supportive care. That has changed. Several drugs have now reached the market or the finish line, hitting the disease at various points in that 4-hit chain. For comparison, sparsentan works downstream, at the level of glomerular pressure and scarring, and never touches a B cell. Budesonide is a targeted-release steroid that acts locally in the gut, where much of the faulty IgA1 is thought to start. Sibeprenlimab blocks APRIL alone. And atacicept is the shift we just walked through. It is the first B-cell modulator to hit both BAFF and APRIL together. Atacicept cuts off the signals that keep B-cell alive and productive. Starved of those signals, the cell dies. Antibody production slows, and fewer complexes ever reach the kidney. The early data shows a real drop in proteinuria. What we're still waiting on is proof that this translates into kidneys that last longer. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.